Hi, this is Julie Levinsky. I'm the Associate Director of Digital for the Christopher and Dana Reeve Foundation. I'd like to welcome you all to today's live chat with Nurse Linda. Linda is a leader and a provider of rehabilitation nursing for 40 years. She also writes our interactive Ask a Nurse blog, an evidence-based community forum, and she conducts these monthly webinars where we get to ask her questions in real time. But keep in mind, too, that she's also on our online community forum every Wednesday evening answering your questions there. So now I'd like to turn it over to Linda. Hi, Linda.
Hi, Julie, and hello, everyone. Thank you for tuning in today. It's always nice to spend this time with you. It's been kind of a long month, it seems like, since the last time we spoke, so I'm happy to be together with you again today. I've been writing a lot in the blog about grief and loss lately. It's a topic that is certainly one that is prevalent with anyone who has any kind of chronic illness or disability, and it's just something that is sometimes very difficult for people to bring up, and so I think it's a good forum in the blog and on the webinar to talk about grief and loss. Sometimes people think that when they have a chronic illness that grief is only a property of when somebody dies or when you have a loss of a family member or a friend. But grief and loss happens to all of us at different points in our lives, depending on what's going on. It certainly happens with the loss of a loved one, but it also happens with a loss of any kind of our function or even a change in our lives. And sometimes we can have some grief and loss really involving things that we're happy about. So say our child gets married, and we're really happy that they've found someone and they're starting this new life, but sometimes there's a little bit of grief, too, of where we will miss that direct relationship that we had with our child because now they're going to be focusing on a different part of their lives. I mean, it's not going to be absent, but it's just going to be different. So sometimes people don't really put the emphasis on grief as maybe, how they're feeling their emotions at the time. Certainly when you have a loss of function or any kind of major change in your life is a time for grieving. And it would be nice to say, well, that will last this many days and then it will be over, but it just doesn't work that way. It's so different for every single one of us. And a lot of it has to do with the chemical makeup in our brains of how we deal with changes in our lives, good or bad. So just as if you think about everybody's face is a little bit different, well, the brain of everybody, of humans, all works the same, but it's a little bit different. Just as your face is unique to you, the way the details of your brain work is going to be unique to you. It's going to be just the same as everybody else, but just a little bit different because you are a unique and special person. So in thinking about that, always remember that the way the chemicals react in your brain, you have a lot of nerves and neurons up in your brain, and they're sending signals all the time. The brain's constantly busy working. And so sometimes when these signals get sent, it doesn't matter if, what your brain makeup is. They can be miscommunicated at some time. Now, if you add something like paralysis, spinal cord injury from disease or from trauma, the way that your chemicals in your brain work can be altered by those kinds of functions. There could be some kind of, I think of the nervous system as like Jell-O jigglers. If you shake one part of the Jell-O jigglers, it kind of twitches all the way over to the other side of the bowl. So if some part of your nervous system has some kind of damage or insult to it, it kind of affects the whole way your nervous system works. So we have to be very careful, and a lot of times people, for many, many years, depression and grief and loss were really not well understood and how that worked in the brain. And so people would give misinformation, not on purpose and not trying to be mean, but just because they didn't have the right information. And so we know that a lot of grief and and loss and depression all ties into the chemical workings of the brain. So we also know now that there are ways that chemicals can be brought more into a normal phase, and that is through medication. That's one way to help the chemicals in your brain balance out. We also know that therapy, especially cognitive behavioral therapy, can help people who are dealing with grief, loss, and depression, in that it's a talking kind of therapy where you have several sessions. And basically what you're doing is learning to identify the problem that you're dealing with specifically, because sometimes it's kind of arbitrary. It's hard to get kind of to the root of it. So it's helpful for that. And then it's also helpful for creating new behaviors and ways of dealing with problems in your life. Now, in more extreme cases, electroconvulsive therapy has been helpful for people with extreme depression. And I'm talking about people who have depression that is just totally debilitating their whole lives, so that they cannot even move, or they cannot even attempt to try to move. So it's like really extreme depression. And then also there's a lot going on with a new therapy that's electromagnetic therapy, where a magnet is placed on the brain, on the outside of the skull, but over the brain, and it helps the flow of the chemicals in the brain work better. So that's kind of a simplistic version of what happens with that, but it kind of gives you the idea of what's going on. Those are more extreme treatments, and so we won't really focus on those. You'll need to work with your healthcare provider, but to decide what treatment would be best for you, if it's medication, if it's behavioral therapy, or if it's more advanced kinds of treatments. So it's something to keep in mind. It doesn't mean that, you're going to, if you talk to your doctor about depression, you're going to be thrown into these really more severe kinds of treatments. But it's good to talk every time you go to your healthcare provider to ask for screening for depression, to see what's going on with you in your life. So it's not at all uncommon after paralysis to have some depression, because you're having this severe trauma in your life. There are 5 stages. There's a doctor, Elizabeth Kubler-Ross, who with her team identified stages of grief. And she worked with people with all kinds of diagnoses who were in the hospital that were terminal. I believe she went to some people's homes, and the people knew that their life was ending, and she talked to them about what that process was like. She came up with these 5 stages, and the first one is anger. And I always think about that stage, because when I first meet people with a spinal cord injury, anger and isolation is kind of what they're dealing with. They don't accept the fact that this situation has occurred. Now, I think that's a good thing. I think that anger is kind of a good protective mechanism, because if you wake up one morning and you find, oh, I'm paralyzed, oh my goodness, this is such a huge trauma, that I think that period of anger really lets people have time to let their bodies understand what's going on, let their minds understand what's going on. It's kind of a protective mechanism. And so people know that this is a tough situation, and people are willing to deal with that. And so you just have to learn how to channel that anger into appropriate methods. So some people get really angry and they're going to work harder. Some people get angry and they kind of isolate themselves and don't really participate. And whatever you choose to do, however you choose to deal with that, is going to be an appropriate thing for you, because we all deal with problems in different ways. So feel free to do that. But there comes a time when you have to learn to channel that anger appropriately. So it's not appropriate to be angry with your family member because you have paralysis or you have some other kind of healthcare problem, but to talk with them and remember that they might be going through these stages too, because as a family member, their lives are going to change as well. After anger, people usually go into a stage where they're really in this denial of not accepting what's going on. And I see this a lot, especially in the ICUs. I have yet to meet a person who has a spinal cord injury or the family members that doesn't say to me, I'll be the first one to get up and walk out of here. And I think that would be great. I would love it if you would. But in the meantime, let's deal with the situation at hand and what we have to do. So I never try to tell people, oh, that's not going to happen, because in my heart of hearts, I know that one day somebody is going to get up and walk out. And advances are working so quickly, so that would be a good thing. Then people tend to enter into a bargaining stage. It's usually with God, but could be with other people. I had a patient early on in my career, so years and years ago. It was an 18-year-old fellow that had taken a dive into a lake and suffered a high-level spinal cord injury from a fracture in his neck. And he every night, and I was working in the evenings, and every night he would tell me, Linda, if I could just take that dive over again, I would just move over a couple of inches and I would be okay. And he was always doing this bargaining, if only I could do that again. And it's fine to think about those things and it's fine to wish for those things, but the reality of it is that you can't do it over again, and not to turn that anger in on yourself. So that's the important thing about the bargaining stage, is not to get stuck in there. Now, it's okay to have a period of time when you are bargaining with God or with somebody else, and that was his time where he was bargaining with me. I could do nothing with it, but comfort him. But it was so powerful that I still remember it to this day. And if I could, I would have loved to have given him the opportunity to do that one dive over again. That would have just been great. After that, people tend to fall into depression. That's the fourth stage of the grief process. Now, everybody handles depression differently. Two people can be in the exact same situation. One person will kind of really just not let the situation integrate into their life, and the other person will become consumed by it. Because our brains work differently, just that little bit of uniqueness to us is how we react to depression, just a little uniquely from the other person. If you think about, you're in your car, you're driving, and somebody cuts you off. One person in that situation will be like, oh, well, nothing happened, I just keep driving and forget about it. Another person is in that same situation, and they'll be telling you 2 weeks later about how this guy cut them off on the road. They just can't seem to let it go. And it's just a matter of, this is the way that our brains think about things. It's just the way we're made up. So, don't let yourself get beat up by it. It's just the way it is. A lot of people will say, oh, depression, that's a mental problem, and you don't want that, so just tough it out. No, this is not the time to tough it out. It is a medical condition. Depression has to be treated, or should be treated, just the same as if you have a UTI, if you break your leg, if you need an eye exam, if you have any other kind of medical condition, people will tend to seek treatment, but somehow because of the old stigma of mental health issues, people will tend to put off that treatment. But don't put it off. Like anything else, if found early and if dealt with early, the treatment can be maybe a little bit less than if you let it go until it becomes so severe and really consumes your life. So be sure and get depression. Talk to your healthcare professional about it. Talk to your family members about it. If you tell them, I'm just having a struggle with this aspect of my life, would you please not bring up these things, or could we bring that up at a different time? Just be open with your family members to say, I'm really having a struggle dealing with this situation right now in this moment. Could we talk about this later? And then maybe the next morning after you've had a good night's sleep, maybe you feel a little more refreshed, maybe you're ready to deal with it. Now, that doesn't mean that you get to put off your activities that you have to do, like catheterizing and bowel programs and exercise and all that. You still have to go through all your functions of your daily life. But if you have some kind of issue that's bothering you, maybe you have a confidant in your family, maybe your caretaker can help you through that particular problem. But be sure and talk to your primary care physician or whoever's doing your primary health care, and they will be able to guide you to the appropriate resources. If you need a specialist, a therapist to help you, a counselor to help you. Some people talk to their clergy people. You can find whomever you feel most comfortable in working with, and be sure and work with those people. And then the final stage of grief is actually acceptance. And so acceptance is when you say, okay, this is the way it is. Maybe I don't like it, but this is the way it is. So I'm going to live my life now in this situation. That doesn't mean that you are gleeful because you've had this loss, but it just means that you're able to put it into perspective, continue on with the things that you have to do with life, and move forward with your life. Unfortunately, there is a thing that was discovered. It was first written about in the pediatric literature, and that is this thing called chronic sorrow. Chronic sorrow is something that happens to people that have these major changes in their life when they feel like that they can't do things as they did before. And it gets very fatiguing. It gets very tiring, always to have to be trying to deal with some kind of adaptation and changes. And it is fatiguing, and it is tiring. But people tend to accept the way that things are. After a while, at first it's like, oh, I have to catheterize. Now, wait a minute, what do I do? And you have to think about all the steps. After a while, you get to know, okay, I know what to do. I know where my equipment is. I know the procedure, and you do it. And then after an even longer time, you start thinking, well, I have to go to the bathroom. Boom, this is what I go do. So it's kind of a process that people work through. But this issue of chronic sorrow will pop up in your life periodically. And you think you've got it all pulled together, and you think you're doing real well, and then all of a sudden, boom, something happens. You're in a different facility. You don't know where the bathroom is. It's not conducive to doing intermittent catheterization. You're trying to get into the stall that's supposed to be accessible, and it's not really accessible. You're used to catheterizing on the toilet, and you can't transfer onto the toilet. And this is where the chronic sorrow comes in, because it can snap you right back to those early stages of grief, way back into the anger and denial stages. Now, hopefully, as you go on through life, you move through them a little bit quicker. But it would be lovely to say, oh my gosh, my grief is over, my depression is over. And then you have these little, now they have the word, these microabrasions. A little something happens, and all of a sudden you're snapped right back into it. So I have a lovely friend, and her husband died over 50 years ago. And we were out at breakfast one time together, and a man came in who had the same condition as her husband, and she just started weeping. She had the chronic sorrow. She had gone 50 years, had lived without her husband for 50 years, had adapted, had moved on with her life, had gone through the grieving process, and here it was 50 years later, and she was snapped right back into that moment. So we all know that they're out there. It happens to everyone. We know that there's treatment out there, so don't think you have to go these things alone. Anyway, I just wanted to talk about that a bit, because I think that people try to ignore it, or try not to think about it, or try to think, everything's rosy. Well, it's not. And we all have life challenges, some of us greater challenges than other people. And so, but when it's your problem, it's the worst problem. And that's what I try to tell all the nurses that I work with. It doesn't matter what anybody has. It doesn't matter who's sicker in your mind or who's got less problems in your mind. When it's that person's problems, it's the worst problems. So always be present in the moment, and we all struggle with the continuation of our lives after this huge event that's happened. So let's answer a few questions. It's always interesting to see what people are thinking about when they write in their questions. So the first one is about a person who will be flying across the country on a 6-hour flight. And plus, they'll be the first on and last off, so needing assistance to get on and off the plane. And that takes a while, and then you have to wait for everybody else to get loaded on there. And so, and then you wait for everybody else to get off before they come and get you off. It would be 8 hours without being able to cath. So what advice do you have? A Foley catheter depends. Well, first of all, you don't say if you're a male or female. So we'll just kind of break it down by that. Sometimes men who do intermittent cath, depends on who's sitting around you and how the flight's working out. If you're in those first rows of seats and you're right up front, sometimes people will lay a blanket over their shoulders, and somebody else will cath right on the airplane. Now, depends on who is sitting next to you, because last time I flew, oh my gosh, I was inundated with all these signs about sexual harassment on the airplane being a federal crime. And with the Me Too movement, one of the great things many great things have come out of it, but one of the great things has come out of it is that so many people are accosted on airplanes. I had no idea. And so there's all these signs. So you have to be very leery about catheterizing. If you with your family on that row, or nobody else, you can kind of hide what's going on. That is a possibility, but very dangerous right now. So there are some people, women, it's more difficult because of positioning. You can't really catheterize sitting in the airplane seat. Now, some of the larger airplanes, and you will want to call or check online and see what type of airplane you're going to be flying, because these cross-country flights, some of the airplanes are larger, and they actually have a handicapped bathroom on the plane. Difficulty being, how are you going to get from your seat into the bathroom? If they allow your chair to be on the plane, then you have that option, but you might not physically be able to get to the handicapped bathroom, even if there is one, which would be iffy. So, okay, but just find out if there's a handicapped bathroom, and then talk to the people at the airlines and see what kind of preparations they have to get you from your seat to the bathroom, because they might have one of those little I call them micro chairs on the bathroom to get you from point A to point B. Now, so some people cath right before, and then they don't cath again until they get off, but that's a long time to wait. You might have some spasms. You might have some overflow. The dangerous thing about this, if you decide not to cath during those 8 hours, now some people wait 8 hours at night not to cath. You want to watch your fluid intake. It's not something that is advisable, but some people do wait 8 hours in between catheterizations. The big problem with that is that you can have that reflux. Your bladder gets full, your sphincter to let the urine out is tight, and where's that extra urine going to go? It's going to go back up your ureters right into your kidneys, damaging your kidneys, because your kidneys don't hold urine. Only your bladder holds and stores urine until it's time for it to be expelled. So that's a huge problem with that. You will need to talk to your healthcare professional if you could go 8 hours without that. If you haven't had testing, urodynamic testing, you definitely would not want to do that. The other thing that people do is sometimes they do insert a Foley catheter. A lot of women in particular will insert a Foley catheter for the trip, and then they don't have to worry if the plane's late. Oftentimes planes are late, they get diverted, things happen, and you're waiting to catheterize, and now it's not 8 hours, but it's 9 hours, it's 10 hours, and you're really in a danger zone. So a lot of times people will use a Foley catheter. If you're feeling uncomfortable that you might have some leaking on the airplane, you can use a Depends or some kind of diaper, but you want to be sure if you do something like that, that you're not just letting things leak, because that's this overflow, and you could have the chance of it backing up, in the urine backing up into your kidneys. Depends also, they have some barrier there so that the urine is not up against your skin, but since you've been incontinent, the urine is on your skin. So that's going to be breaking your skin down the whole time you're wearing that. They're also waterproof, which means they're kind of airproof. So air is not getting to your skin while you have that on there. A lot of people who wear Depends or other type of urinary undergarments complain about how hot they are because they're not letting the water seep out. They're not letting the air get in. So if you're worried about an incontinency on the plane or any place, you can certainly use those now and again. Some people will use Foley catheters, but check and see if you're on a long flight like that. There might be a place where you will be able to slip into a bathroom and be able to catheterize. That would be the ideal. Otherwise, those are some of the alternatives that people do when they're on long flights. The next question is about understanding that it's important to have a regular bowel program, and the question is, how important is time of the day? So, for example, they had their bowel program today at 9, tomorrow at 1, Friday at 8. So the question is, how important is timing? In bowel programs, timing is everything. You really need to do a bowel program. Most people will do a bowel program every other day. Now, there's a rare person that will do it every day because of the way their diet and because of the uniqueness of their bowel. They feel more confident, they have less accidents, and so they like to do it every day. There are some people, and these are even fewer in number, that will do their bowel program every 3 days. And these are people that eat like little birds. This is not really something that is highly recommended because you need to keep the bowel moving and not have it not have stool linger in your bowel because it gets too dry. But there is rare birds, but most of the people will do it every other day, their bowel program. Picking the time of day is critical to the success of your bowel program. So it's very difficult, I know, because you're doing something different every single day. Your schedule changes. But some people will elect to do it in the morning after breakfast, and some people will elect to do it in the evening after dinner. Now, there are a few people that will do it after lunch, but really breakfast or dinner is usually the better times. And the reason for that is that in the morning you've had a long time since you've consumed food. The minute you put food into your mouth, your bowel starts working. And so it kind of rests at night. It never stops, but it kind of slows down at night. So when that food hits your digestive tract in the morning, your bowel starts really gearing up with a vengeance. And so that's the best time to do a bowel program. Now, for some people, that's just impossible because they have to get up and get to work, and the time to do a bowel program might be unpredictable for them. So they'll do it in the evening time before they go to bed. You can still have a cracker or something, a little snack right before your bowel program, maybe after dinner, where you've consumed food that gets your bowels started up again. So if you're bouncing around with your bowel program, you can vary by half an hour, and it will still be fine. But to really jiggle it around by different hours of the day, you really need to stick to that routine because it used to be called bowel training, and really what you're doing is you're training your bowel to empty at that particular time. And your bowel can be trained to do that. And so that's why you need to pick a particular time. You'll have better results. Your program will go faster. I know some programs are so slow, and when you're jumping around like that, that will certainly affect your bowel program. And then supplementary to that question is one about catheterization. Can you catheterize too often? Their doctor prescribes every 4 hours. Technically, what we do is for catheterization, it's recommended for intermittent cath that people catheterize every 4 to 6 hours. So people who have newer injuries, they're adjusting their bladder program. Maybe they drink more fluids. 4 hours is kind of the minimum time in between catheterizations, so that's perfectly fine every 4 hours. Some people can stretch it out a little bit longer, but it depends on the amount of fluid that's being taken in, and it depends on the amount of fluid that you hold within your body as well. So some people have a lot of edema in their feet. When they put their feet up, that edema fluid gets returned to the heart, and then it gets expelled. So people, learn their schedules and catheterize at that. So catheterizing every 4 hours is not too often. If you have problems with your sphincters and the sphincters where the urine comes out, and your bladder working in unison, or if you have a lot of spasms, the doctor will want a lower volume in your bladder at any time, again, to avoid that reflux back into the kidneys. That is really dangerous, is when urine backs up the ureters and gets back into the kidneys. That causes kidney damage, and you can lose your kidneys. So it's very important. So if your doctor prescribes every 4 hours, then I would highly recommend to keep to that schedule. You can ask him what's the reasoning. You can ask him if I could stretch it out to every 6 hours. But find out once you know the why. So if you know that you might have reflex problems or you have large volumes, this is why you need to do it for every 4 hours. That will make you more comfortable with that. But 4 to 6 hours is what's usually recommended. So there's some reason why that doctor wants it at 4 hours. The next question is, how many times a week minimum should you have a bowel movement? I have a C5 injury, and please give some tips to a healthy bowel. Well, there are a couple of things. As I previously said, every other day is the recommended. Now, some people, and especially in the older population, when you talk to patients about their bowel and bladder, they tell you a lot of things, and it's always kind of interesting. Older people, there must have been something in our grandparents' generation or parents' generation where people were told they need to have a bowel movement every day, that's healthy. Very rarely do people have bowel movements every day. Now, some people do, because if you've ever been in a working environment where people are having their coffee and you go into the bathroom about 10 o'clock in the morning, the smell in there is unbelievable because everybody's having a bowel movement, because hot fluids tend to make your bowel work even more quickly. And so people have their coffee and then they have a bowel movement. Okay, it's very graphic to discuss, but let's face it, this is it. But most people don't have a bowel movement every day, but they usually have one every other day, and that's why the every other day signal. So it's 3 to 4 times a week, depending on when your every other day hits. So it's every other day is for the bowel program. Now, tips to having a healthy bowel. Well, you need to have something in the bowel to move along. So if you eat a lot of processed foods, if you don't drink much, that doesn't provide fluid to move the substance along. Once you eat food and you swallow it, it goes into the stomach, the digestive enzymes start working, breaking down that food. As it passes from the stomach into the small intestines, bile from the gallbladder will help further break down the food substance. So when the food substance gets into the small intestines, it becomes a substance called chyme. It's like sludge. It's like a really, really thickened fluid. It's actually a dark green in color. And this is moved along all through the small intestines while nutrients and fluids being extracted. So if you want a healthy bowel movement, you need to drink fluids. That doesn't mean to stop and start drinking water continuously. You have your bladder program to consider, but if you can increase your fluids, like every couple of weeks by just a swallow or two, you can kind of build up your fluid intake. Now, you would have to monitor your bladder program to make sure that you're not getting over 350 to 400 cc's. Sometimes larger men bladders will hold 450 cc's. but women 350, men about 400 cc's in their bladder. So if you're catheterizing more and taking out more than that, you might need to catheterize more often. But if you can increase your fluid, water is the best. Fruit juice will add a little bit of fiber, but not that much. It adds a lot of sugar, which is a complication for spinal cord injury. Individuals who have spinal cord injury tend to have a higher risk for diabetes, so you want to watch your sugary intake of drinks. Warm drinks will help the bowel move a little bit faster. When that chyme gets into the large intestine, there's still nutrients that's being extracted, but it becomes more, the chyme becomes drier like stool, and then it's collected in the rectum until it's time for removal. So any kind of roughage that you can get in your diet, most people who eat a normal, healthy, balanced diet will have enough roughage. After a spinal cord injury, you may need to add roughage through taking a fiber. Unfortunately, they call it fiber laxatives. We never recommend laxatives for individuals who have spinal cord injury with bowel programs because they are very unpredictable and it leads to a lot of incontinence. Plus, you can become addicted to laxatives, so to speak, in that your bowel won't work without having the laxative. So it's an unfortunate choice of words that people call fiber laxatives, but these are things like Metamucil, Citrasil. It gives some grit into your bowel that gives your bowel something to work with and push along. It comes in all kinds of varieties, so you can get powders that you mix with your drink that you can take in the morning time with some fluid. Mix it together. There are flavors. There's kinds that have no grit. You don't feel the grit in your mouth. It just tastes like drinking a glass of water. If you don't care for the fiber, you don't want that much intake at that point of your day because of your bladder program, you can get crackers or wafers. You still have to drink the water, though, to moisten it so it doesn't harden in your bowel. But getting some roughage in there, and then to have a healthy bowel. The other thing to remember is when you do your bowel program, not to be so aggressive. I just see people thinking, I have to do this bowel program, and they just start jabbing at themselves. Okay, so slow down and be very gentle. You're trying to relax your sphincter. The more you jab at your internal sphincter at your rectum, the tighter it's going to become from spasticity if you have a higher level injury, and it's really not going to do anything if you have a lower level injury. So you want to be very gentle and smooth in your bowel program, and that will help. Be sure and lubricate well before you do a bowel program. The other thing is for bladder and bowel, if you can supply some kind of movement to your legs and your abdomen, so doing wheelchair push-ups, anything you could, moving your legs even passively, that helps the muscles all work together. So if you're moving your legs, you're going to be stimulating those muscles in your abdomen just a little tiny bit, and that will help create that movement of muscles, which helps empty your bladder and helps empty your bowel as well. So those are the things to do. The next question fits into this. Some of the suppository inserts are very stiff, and yes, they are. So sometimes therapists think they're unsafe for use in the rectum. And what's your experience? Sometimes they are kind of stiff. Well lubricated will certainly help. They shouldn't be ever inserted without lubricant on them. Sometimes you need a little bit of stiffness to help relax that internal sphincter, so you have to have an inserter that goes long enough to reach your internal sphincter, and they're made so that they do. So the finger is much more forgiving, I guess I should say, because you can kind of feel the internal sphincter, you can feel things relax, you can get that sensory feedback on what's going on. When you use an inserter, you don't get that feedback. So I think here again, it's the idea of how rough people are when they're doing their bowel program. So if people are using a gentle approach if they're using an inserter, if they're lubricating well, if they're being gentle with it, they seem to be okay. I've not heard of anyone having a problem from these. Maybe they've seen different kinds of events with rectal problems from using some of these, but I'll pretty much bet it's the aggressiveness of their use, and that people are so aggressive. They keep thinking that the more forceful they are with stimulation, the better bowel results they're going to have. When in reality, the whole idea of digital stimulation is to relax the internal sphincter, and it also provides some input to the bowel so that peristalsis will help bring the stool down and out. But the more aggressive people are with this, the slower their bowel program is. It's just the opposite. You want to be as gentle as possible. So that should take care of the problem there. The next reader says that their husband was in an accident 4 years ago. He has a broken neck and a torn spinal cord. He's recovered a lot of function, so that is great. But he has a lot of joint and muscle cracking and popping. Is this normal? Yes, it is normal. Not everybody experiences this, but the less we use our joints, there's fluid in all of our joints, and so there's some buildup that happens when you aren't using your joints as regularly as you could. So sometimes, people get up from a sitting position and their knees pop. That's this fluid inside the joints that's collected in there. It's always there, but a little bit more is collected in there from being sedentary. So oftentimes that's what that popping noise is from. If it's from the joints and the muscles I just moved my foot and my toes all popped. So, these things just happen. It's pretty normal. So maybe moving a little bit more might help reduce that. If there's no pain or if nothing's bothering him with it, it's just this popping noise. It's just from lack of movement. So moving it more either actively by getting up and moving around a little bit more, or passively by picking up your leg and your joints and just moving them a little bit periodically will certainly help reduce some of that problem. Now, if you're finding that there's a lot of pain with it, it could be that maybe there's a bone that has been fractured or something, and so if there's any kind of pain or problem, or if you're just concerned about that, be sure and ask your primary care physician. We're on the blog and we're speaking very generally. If there's something that, has happened where maybe he's moved his leg too aggressively, or it's been hit up against the side of the bed or the wheelchair or something, you might want to have that checked out. So, I just speak in general about that, but popping and cracking, we all have those little things that we do, more so when we don't move as much. We get stiff and then our joints pop a little bit more. Okay, here's a person who has a C6 injury and his body does not sweat besides dysreflexia. How can I get my body to sweat? Well, okay, if I had the answer to that, boy, would I be a rich person. Actually, after a spinal cord injury, your body does not sweat below the level of the injury. Now, ironically, on the different side of the same coin is that when you're cold, your body will not shiver to warm you up. So those functions are lost. So how do you get them to work? Well, some things you can do is to provide movement to your body, which will even passively, which will help create some heat in your body, even because you're moving those muscles around. The more important thing to do is to keep the temperature of the environment that you're in to be conducive to your body temperature. So people have better luck in controlling their environment than they do to controlling their body. So for sweating, sometimes if you go out, you want to do something, it's been really hot across our country. Today in the Midwest, we're having a little bit of rain with some relief, so that's good. But we've been having these really horrible heat waves. If you need to go out and be in that, be cognizant of how long you're being out so you don't overheat. Some people will use those spray bottles and will provide a moisture on their skin. Now, you don't want to get too moisture because, you don't want to be laying in anything that's wet. But some people will create a moisture on their body that way. Sweat is nothing but water beads that come out of our body that our body automatically uses to cool itself. So you can create sweat by squirting with a little spritzer and cooling your body off. Wear a hat. If you have one of those spritzers with a fan, you can fan yourself. There's some towels that you can get that hold water and will act as a coolant. You can take a towel or a washcloth, wet it, and put it in your refrigerator or freezer, and then use those to cool your body as you go. You want to be sure that you don't get frostbite or get too cold. And then in the wintertime is to dress appropriately. So sometimes people say, well, I don't feel the cold, so it doesn't bother me. But it still does bother your body. You just don't know it's bothering your body. So you have to take precautions. And sometimes when your body temperature gets out of regulation, about the only thing you can do is to go to sleep, and then your brain kind of resets itself. So that is a huge problem, but especially in this hot weather, you want to be very careful about providing some kind of sweat, not staying out too long, trying to stay in air conditioning whenever you can. Another thing to be really leery of is if you're going to be traveling in a vehicle, to try to get somebody to cool the vehicle before you get in it, because when you get into a hot car, it's just overwhelming. Another slippery slope is humidity. So even if you're in an air-conditioned house, if it's so humid, I know here in the Midwest it can get very, very humid, and you can be in an air-conditioned house, air-conditioned office, and the humidity is still there. Heat, you can get out of the heat and your body will cool down, but when it's humid, it tends to collect in your body and keeps building. Even if you go to a cool place, if you've been in the humidity, it will still be present in your body. It takes a longer time to get rid of humidity. So just be very careful about the heat, especially in these really hot temperatures. Okay, here's a question that comes up really a lot. And so, actually the next two questions, and it's about having a healthy and active sex life after becoming paralyzed. And this person's thinking about reentering the dating scene and is worried about how to broach the subject with a new partner. Well, hopefully, if you're thinking about a sexual experience, you are familiar enough with that partner and hopefully comfortable enough that you can bring up these issues. It's best to be just frank and very clear about it, that you're interested in that person in a sexual way, as well as with their other attributes, and that you have some differing abilities, and then have a face-to-face talk without that, because without that kind of talk, the other person might not have any clue or any idea about what your life is like and how things have changed. Now, for men, there are a lot of medications that can be helped to use for erection. You will want to talk about with your physician the one that is that will work best for you. There are oral medications that you can take. There's also injections that are help with erections that are very beneficial. Even still, these are injections that are injected into the penis, and so some people are just can't handle that thought, but they're very successful. So that's why they're so popular. So be sure and talk about it. For women, there are not that many medications or devices. For men, there are also vacuum pumps or there are implants that can help with the erection. Now, as far as for women, there's not that many. There are some medications that are being used, and there's a lot being worked on. The important thing for a woman is to be sure that you are using a lubricant because you might not self-lubricate. So be sure that your partner is using a lubricant. And then as far as orgasm is mostly in the brain. Now, people don't like to think about this. They think the orgasm's in their genitalia. And certainly the stimulation starts there. It's a cause and effect kind of thing. But many people use their other senses during the sexual experience. So if you can teach yourself to have erotic thoughts, to think about orgasms, people can have orgasms after spinal cord injury. It just might be different than the sensation they had prior to spinal cord injury. Certainly you can still have a satisfying sex life. You can still satisfy your partner. So you need to think about talking with a new partner and getting really comfortable. Start out with just some kissing, or don't start out with intercourse right away, but build up to these kind of things. It helps the psyche, it helps the mental part of sex, and that way you tend to have a more successful experience in that sort of thing. Now, if you're not sure what kind of positions to use, there's all kinds of information on the internet where there are pictures, there are videos. At the Christopher and Dana Reeve Paralysis Foundation, there is a lending library. So instead of investing in a book, you can borrow it from the library and see if it has the information, some positioning pictures, some different techniques. See if that helps with what with what works for you. If not, you can return that book and check out another book. So there's a lot of resources that are available to you to help you with the mechanics of it. It will be slightly different than how it was prior to spinal cord injury, but still very satisfying. Okay, the next question is there any exercise to control spasticity in the legs? And yes, any kind of movement or weight that's put through the legs will help with spasticity. It doesn't necessarily mean that it will take it away, but it certainly will help. If you have movement in your legs, be sure and move your legs. If you can't move your legs, but you or somebody else can move your legs for them, or you can stretch out those muscles, that helps reduce spasticity. Now, it may be only a temporary fix. You might need something a little stronger, some medication, or maybe some Botox to help reduce your spasticity. But if you have a mild case of spasticity, that's what a lot of people will do, is do their passive range of motion exercises that will help do that. If you're in the middle of a spasticity episode where it develops into clonus, so there's like a rhythmic beat of the muscle, so a lot of times people will have in their legs, if they have a thoracic or cervical injury, they have more spasticity, and so sometimes people will have that spasm in their leg. If you continue to stretch that muscle so that it fatigues it, or have somebody stretch that muscle, you can break that spasm. With clonus, if you just put a light pressure on the top of the knee, you can usually stop the clonus from occurring. That's when somebody has, like, it looks like they're tapping their foot, or it looks like they're shaking their leg, and it just keeps going until the muscle fatigues. Another thing to do is to get a standing frame, and to stand in the standing frame, which will also help fatigue the muscles. So both of those things help with spasticity, although for some people they still need something more. But the first line of defense for spasticity treatment is to provide some kind of movement, which is stretching those muscles, which is helping to fatigue them so they're not becoming so tight. Okay, we have another question. The best way to hire a part-time caregiver. The best way to hire that is to find somebody. So how do you do that? You can contact an agency. It doesn't mean you have to accept the first person that they send to you. You can try out a couple of people with an agency. A lot of people will place ads or will go through word of mouth. I'm looking for somebody to help me. Sometimes college students who are in the medical profession will take a part-time job like this because it gives them the experience that they need for their profession. Finding somebody, there's a variety of ways you can advertise for someone. You can go through an agency. You can go through word of mouth with your neighbors, with your friends. You can call organizations in your community. So different organizations have banks of people that are willing to help. If you are on the web with somebody in your community, they might know of somebody. Sometimes you can call back to the hospital or call your local hospital if you went to a special spinal cord injury center. Call your local hospital and talk to the social work department. Tell them you're not a patient, but you're looking for somebody. They often know people who are looking for this type of work. Check with your physician. They might know of somebody. There might be somebody who had an attendant and they now, for some reason, their schedule has opened up or they're looking for more work. So people who are in the community tend to know other people, and they tend to know about recommendation ideas for them, if they enjoyed working with them or if they did not. Now, you don't necessarily need to have somebody do these things who has experience. You can train them yourself. You've been educated at your rehabilitation center and what needs to be done. Maybe you've had a family member who's doing it. So you can have somebody help train or educate this new person in how to do these activities. Before you hire the person, make a list of everything that they need to do, every single little detail. Now, you can add to that list or you can subtract from that list. Sometimes if you hire somebody to come in and do your bowel program and now you want them to also do your shower, sometimes they don't want to add new activities. So put everything in that you can possibly think of. Think about the type of person that you want. If you're the kind of person that wants to be in control and direct, have somebody who is willing to work with you in that regard. If you're the kind of person who wants somebody to just come in and do it, then hire somebody who's a little more self-motivated. Whatever you do, do not lose control of your own body. You are the person who's in charge of your body. So even though that person is doing your skin checks and looking to see if you have any red spots, any potential pressure injuries, you look as well, because if they are sick for a week and they can't come to work, they go on vacation, and you discover a red spot, well, you don't know how long it's been there. Remember, you are in control of your body. Look at the results of your bowel program. See what that is like. Know how long it takes. Know how long it takes before you do another digital stimulation. Be the captain of your ship, and that's going to be the very important thing to note. Standing frame, is there something I can do about swelling in the legs? I really wanted to talk about this because standing frames help you put a weight through the long bones of your body. But whenever your feet are dependent, you're going to develop edema in your feet if you're not mobile, because when we're walking around is when our muscles are really activated that help return a lot of that edema. So when you have your feet up higher than your heart is when the edema is going to go away. Now, when you get in bed and you put your feet up in bed, your feet are equal with your heart, and so a lot of the edema will go away. If you have a severe case of edema, you need to put them higher than your heart. So if you're sitting, you need to be up higher than your heart, which is going to change your sitting balance and your pressure areas on your bottom. So you need to be careful about that. When you're laying, you can put your feet up on a couple of pillows, make them higher than your heart, and the edema will flow out of your legs. Now, be careful that it doesn't collect in the small of your back. What we want it to do is to get it back in the circulation and excrete it through your bladder program. Another thing you can do is first thing in the morning when your feet are the least swollen, you can put on elastic hose, and that will help provide that stimulation to your muscles to help pull that fluid back up out of your legs. There is one question that I really wanted to get into before we go, and our time is up, but I really want to talk about this. And the question is, can essential oils be used in pain treatment for transverse myelitis? A lot of people use essential oils for a variety of things. Can it be used for pain treatment? Of course it can. What we find with any kind of treatment programs is that even with medication, if a person believes it will work, it will work. If it's comfortable to you to do that, go ahead and do that. Just be careful with the massage that you're not massaging too roughly that would stimulate a blood clot. So I think I hear my notice that it's time for me to end. We like to start on time and end on time. So with that, I'll thank you for coming. There's some additional questions. Please feel free to write into the blog, and we'll get your questions answered. So thank you for joining us today, and I'll turn it back over to Julie.
Hi, I just want to thank everybody for joining us today and let you know that this is being recorded and it will be up on our YouTube channel by the end of next week. So please have a great day and look for the next live chat with Nurse Linda at the end of next month. Bye.
And that does conclude today's conference. Again, thank you for your participation.